the data on which we routinely pre-treat these patients who present with non-ST segment elevation myocardial infarction um, stems from trials that were done about 25 years ago. And since then, practice has significantly changed. My name is Dr. Mandeep Singh, and I'm a professor in the Department of Cardiovascular Disease here at Mayo Clinic. And I, on behalf of my co-author, Dr. Marco Walcimigli, we are presenting this review article, which will be published next month in the Mayo Clinic Proceedings. And the title is Pretreatment with P2Y12 Inhibitors in Contemporary Practice. Where do we stand? First, the time to our angiogram has reduced. So, for example, in the CURE PCI trial, the median time to angiogram was between 6 and 10 days. In our more contemporary studies, the time to angiogram is now reduced, and we routinely take these patients to cath lab within few hours. So the benefit of pre-treatment that was seen in the earlier trials may no longer be relevant. The second thing is the practice has totally changed. We have now third generation drug-eluting stents, and what was used, bare metal stents in the earlier trials, may not be relevant anymore. And the new drug-eluting stents that we use, the stent thrombosis rates in those stents are significantly lower, that we don't have to then pre-treat these patients for a longer period of time. The third important issue, which is worth discussing, is that 1/3 of these patients who present to us with non-ST elevation myocardial infarction, 1/3 of these patients have high bleeding risk. So if you give them routinely dual antiplatelet therapy, they tend to bleed more. And so we don't have to then give them routinely these medications that increase their bleeding risk. The fourth thing is that a significant minority of these patients have alternate diagnosis. So they have spontaneous coronary artery dissection, they have aortic dissection, they have pulmonary embolism. They may not even have non-ST elevation myocardial infarction, which was found in about third of patients. So these patients not only were wrongly diagnosed, but maybe wrongly treated. So you obviate the need for routinely treating these patients with blood thinners that may not be needed. And so the practice over time and across institutions and in the world has changed such that we have moved away from pre-treatment in a routine fashion with these powerful blood thinners to giving them only if indicated after an angiogram is performed. So the skeptics of this approach maintain that the ischemic events would be higher if then you give these medications at the time of angiogram, which is kind of refuted by the recent studies, but also by the practice patterns that have since evolved. More recently, there is this data from the National Cardiovascular Research Database Registry of Acute MI, which has shown that the total use of pretreatment across the US institutions has dipped from 25% in 2013 to about 12% in 2023. So in a span of 10 years, the use of pretreatment amongst these patients who present with non-ST elevation myocardial infarction has halved. And the guidelines, which came out just a couple of months ago, are in consonant with the guidelines that were published previously from Europe. Both of them say there is no use of routine pretreatment with these blood thinners in patients presenting with non-ST elevation myocardial infarction. And in fact, the European guidelines mention that there may be a harm if you use them routinely. The American guidelines, which I said uh, was published a couple of months ago, do mention that there may be a room for us to give these drugs only to patients where there is an anticipated delay in performing an angiogram. And also, the European guidelines mention that it may be beneficial only in the patients who are not high bleed risk. So that's something which is very important, that we need to then not routinely pre-treat these patients with blood thinners, but then individualize treatment based on their bleeding risk and based on the timing of the angiogram. And now with the newer agents that are available in the marketplace, both prasugrel and ticagrelor, make the antiplatelet therapy more potent and effective, such that we don't have to then routinely give clopidogrel, which is the previous generation P2Y12 inhibitors, to these patients. Lastly, we also mentioned in the review, um, we summarize all the studies that are available, but also mention that the prediction of three vessel disease and left main disease is at best modest with the risk models that we have available. And so, if a patient is presenting with non-ST elevation myocardial infarction, we can't predict which of these patients will have left main or severe three vessel disease such that they have to go for bypass surgery. And that happens in about 10% of these patients. So if you have given pre-treatment to these patients, there would be inherent delays in performing bypass surgery because the outcomes, including mortality and bleeding risk, is higher in these patients if you take them immediately for surgery, if they have been pre-treated, versus if you individualize treatment and these patients are not pre-treated, you can take them sooner for bypass surgery. So that's a big advantage. And the other thing which came up from the CREDO trial, which was a trial wherein they used 300 milligrams of clopidogrel 3 to 24 hours before presentation in patients who have high likelihood of undergoing angiogram, they realized that only patients in whom the pre-treatment was with Plavix was given for 15 hours or more tend to benefit with pre-treatment. Now, that actually stems from the fact that routine pre-treatment in patients presenting earlier may not be beneficial. So only patients who in whom you give pre-treatment for a longer period of time tend to gain from it. And so therefore, in our review, we said if you are giving clopidogrel, please give clopidogrel only to patients who then need to wait for longer period of time, such as overnight admissions, such as patients who are getting transferred to our institution from other institutions where inherent delays are inevitable. Those patients tend to benefit from pre-treatment with clopidogrel, and not everyone. And so it is very important for us to understand the take-home message from this review article, which is we need to find out whether these patients are being taken for an angiogram. That's one. We need to then calculate their bleeding risk, which is number two. And then we need to find out whether these patients need clopidogrel, which is our institutional policy, or they will take prasugrel or ticagrelor, which is becoming a more prevalent strategy worldwide. If patients are being given clopidogrel, then you don't have to pre-treat them routinely. There's only a segment of population of patients being treated with clopidogrel that stand to benefit from it. As I mentioned, inherent delays in doing an angiogram, transfers, but also patients who are on oral anticoagulants, who cannot take ticagrelor or prasugrel for cost reasons, or in whom it is contraindicated. For example, patients with prior stroke, where you can't give prasugrel, or patients who have side effects from ticagrelor, such as bradyarrhythmias or shortness of breath. In these patients, if you choose to give prasugrel or ticagrelor, there's no need to pre-treat them with these agents, because these agents, as I mentioned before, are much more potent and inhibit platelets much earlier. So once you follow this treatment paradigm, which is illustrated in this review article, everybody would know how to treat patients with non-ST elevation myocardial infarction with P2Y12 inhibitors. At the end, I would just mention that this review article actually is the most contemporary review article that you will ever read. Um, it has wealth of data, which is totally current, and gives the reader the opportunity to not only have the historical perspective of why we started pre-treating these patients, but then why we started moving away from routine pre-treatment to a very selective or individualized management strategy. This review article will be published next month in Mayo Clinic Proceedings, and I urge all the readers to read it. Thank you very much.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.